Welcome to Talking Threads, Healthy Conversations, Zulekha Hospitals. Today we'll speak about orthopedics and rheumatology subspecialties and their hot topics. I'm interested and happy to introduce Dr. Mona Rabie, the Rheumatology Specialist in Zulekha Hospital, Sharjah and Dubai.
Happy to sit with you, Dr. Ahmed Radwan, Consultant Orthopedic in Zulekha Hospital, Sharjah.
Thank you very much.
I will start to ask you, Dr. Ahmed, what are the latest advanced technique in the minimally invasive orthopedic surgeries?
This is one of the most important and most hot topics really in orthopedic practice. The idea of minimally invasive surgeries is to minimize the soft tissue trauma, reduce the patient's pain, reduce the patient's stay in the hospital, improve the patient recovery. That's why in all fields of orthopedic practice we are trying to get minimally invasive approaches. For example, one of the examples is the ACL surgeries, the surgery I like and I did it a lot. I started practicing like 25 years ago and I attended 5 paradigm shifts in science and medicine, means change of the concepts. 5 paradigm shifts, all of them was directed to the possibility and the direction of minimally invasive approach, starting from open surgery, ended up with very minimal arthroscopic approaches and very small incisions to get the graft and put it with better results and better recovery. And of course, in other subspecialties, for example, in foot surgery, again, it is one of my subspecialties, we started with very aggressive and open osteotomies and surgeries. Now, with small approaches, with small incisions, we can do the same job with better results, with better recovery and less patient trauma and complications. It's my turn to ask you, and it is very good and important point in rheumatology practice. When do you decide to use the new tool, the biological treatment, in treating the most important disease you are treating, rheumatic arthritis?
In the rheumatoid arthritis, we start first with the patient with the conventional DMARD. We having the celazopairine, methotrexate, hydroxychloroquine. But when we decide to escalate to go to biological medication, we have many points to decide how to change. First is the disease activity. If the patient have high disease activity, for 3 to 6 months, even with therapy, and still he have high disease activity, we follow with some scales like DAS-28 and clinical disease activity and simplified disease activity, and still he high, we need to escalate. Also, if we have poor prognostic factor like seropositivity, high titer of rheumatoid factor and anti-CB, and also if we have erosion in the joint in spite of the therapy, and also if we have extra-articular manifestation. Also, decision making, we must to share the patient about what he feel. He feel good with the medication, or still he, with all the medication, still he have stiffness and have problem and affect his daily activity, and he need to escalate with us to the biological medication to help him to make his daily activity and improve his function. This is our goal to how to decide. Must share the patient with us, because you know all our disease is chronic disease, so the patient must to be with us in the decision. Type. This is my turn. I will ask you.
Yeah.
How do you approach treatment planning for young patient with osteoarthritis?
Osteoarthritis in young patients, it's a challenging situation. Yes, of course. I think the first point in the approach is to be sure, is it isolated osteoarthritis, primary osteoarthritis, or it is secondary to one of your diseases, one of the rheumatological diseases, because I have to be sure about it. We used to tell the patient with osteoarthritis, we have two major choices: conservative treatment and surgery. And surgery, the gold standard is replacement. And of course, the choice of replacement in young age group is a very difficult choice. What is mentioned, and I used to memorize it and I used to repeat it to the patient, we have to do a sincere trial of conservative treatment, because not all the time the x-rays will reflect the patient's symptoms. A lot of patients have severe changes or moderate to severe changes in their x-rays, but on clinical basis they are not in severe pain. So such patient can be managed with conservative treatment with good results. A lot of issues, reducing weight, reducing some activities like standing, stairs, sitting with knee flexion, exercising to strengthen the quadriceps muscles, medications to reduce pain at time of flare, medication to improve the quality of articular cartilage, injection sometimes, hyaluronic acid and other medications. Once we fail to control the disease with medications and conservative treatments, surgery could be considered. Of course, we'll try to postpone the final treatment with arthroplasty to the last time ever. But sometimes it is mandatory to do.
Now we have a new material found to use to treatment for osteoarthritis.
Yes.
Like VRB, stem cell. So what about your opinion about this materials?
Again, it is matching with the first question. It is some sort of less invasive approach, and it is gaining day by day acceptance and good results. They are not yet gold standard part of our management. They are not yet approved fully by FDA, but we started to use them. We have a good results. Even some of them started to be available in the market, even in UAE. Started from hyaluronic acid and other medications, then PRP, then stem cell. And the problem about them, one of the problems about them is how much they are available in the joint after injecting such material. The problem was that they stay in the joint for a short time. That's why the idea now is to search for some scaffold or some material which can keep them longer. And one of them was available in the market, and I attended a course about it last year. A lot of doctors from all over the world was discussing their results with such new material. It is manufactured by nanotechnology and could be used in limited osteochondral defects to host the stem cell and make them to act for a longer time. The results was marvelous, and I used it in one of my patients. He was a professional athlete with localized osteochondral lesion. He has a severe pain during practicing, and all measures of conservative treatment failed. And I discussed this option with him. He agreed, and we did it. He is still in the recovery phase. The results initially is good, but I'm waiting longer time to finalize my impression about the result. And of course, I'm interested to use it in more patients. One of the attendants in such conference, I told you, he tried to use it in osteoarthritis, in moderate to severe osteoarthritis. According to him, the results is better than doing surgery in younger age group.
So now I ask you, Dr. Ahmed, about other topic you're doing more. It is the shoulder dislocation. How you deal with the shoulder dislocation for the patient?
Shoulder dislocation, especially in younger age group, is a challenging situation because the younger the age, the higher the possibility that the patient would have the dislocation again. And it was said that below the age of 20, the incidence is reaching up to 100%. And there is a new approach that once we have a patient with one occasion of shoulder dislocation in this age group, is to take him to do MRI, and surgery could be the first choice rather than doing conservative measures. Usually the question is, what is the pathology? Where is the problem? Do we have injury of the tissues or fracture of the bone supporting the head? And accordingly, we will decide what surgery could be needed. Usually we will need MRI and sometimes CT, and accordingly we'll decide if we can do just arthroscopic repair of the labrum, the soft tissue supporting the shoulder from the front, or we need to do more aggressive approach by opening the shoulder and transferring some bone to support the bone and prevent dislocation of the shoulder. It is a little bit technical point, but yes, we have to be more aggressive with treating recurrent shoulder dislocation, especially in young athletic patients. From my side, I'll ask you, what is your approach to pick up rheumatological cases?
We must differentiate the patient if he have back pain, inflammatory back pain or mechanical back pain, mainly if the patient come to the orthopedic and take medication and not responding also. So still he has the back pain. This time, this pain will not be simple mechanical pain. It may be other cause. So as inflammatory back pain, we must differentiate that inflammatory back pain improve with movement. and يعني increased by rest. It is the opposite of the mechanical back pain. And also the pain have morning stiffness, mainly all the inflammatory pains with morning stiffness in the morning up to more than 30 minutes. Patient feel he is stiff and if his pain not improve, still he move. When he move, the pain become improvement. Also, if we have associated with other joint, mainly if we have also stiffening the small joint of the hand. Also with us, if we have extra-articular manifestation, if we have skin rash, as in SLE, or if we have psoriasis skin lesion, or if we having Raynaud's phenomena, if we having any other associated manifestation, also give us going to autoimmune condition. Also with the lab, we make lab if we have high inflammatory mediator, ESR, CRB, positivity of antibodies like rheumatoid factor, anti-CB, ANA, HALA-B27. When we make مثلا X-ray, we found erosion, narrowing of the joint. If we make MRI, mainly in the sacroiliac, we found sacroiliitis. All of this give us picture this patient going to inflammatory back pain, even axial spondyloarthropathy or rheumatoid arthritis making also sacroiliitis. In this time, we must make more follow-up and diagnose, then give medication. This time, he will improve his back pain.
Good approach. And again, about the area of overlap between orthopedic and rheumatology. We have sometimes patients coming with some vague pains. We start to treat them as if it is a localized pain due to any other causes, and we don't have a good response. And sometimes we can think about pathologies like fibromyalgia, this vague disease for us as orthopedists. And I'm happy that we have a good rheumatologist in the hospital, because in this situation, I refer him to you. So what is your impression? How would you approach such patients?
Fibromyalgia, it is already the patient when he have vague pain, fatigue, all time he have pain in all muscle and joint, but not refer mainly to the joint, he have pain, so must to educate the patient. The important point for fibromyalgia is the patient education. Because must to tell him it is a central desensitization syndrome and it is not inflammatory, not pathology. But nowadays, some paper, last one I read it, that they searching that fibromyalgia may have autoimmune base also, and maybe after some decade we have specific medication as autoimmune condition, maybe. But until now, it is central desensitization syndrome and affecting the all muscle and the the chemical transmitter, and affects the pain, makes the pain for the patient. So we must educate the patient about his condition. Then we're going to help him with many points. First thing is exercise. Exercise as aerobic exercise and strengthening exercise for the muscle to help him to decrease the pain. Also to sleep hygiene, tell him about good sleep and not to become late in the bed. Also to help him good food and take healthy food, also helping him. We're going also to pharmacological medication. We have FDA approved medication for fibromyalgia like duloxetine, milnacipran, and pregabalin. Help him for the sleep and the pain to decreasing for him, and he become good. Also, he must to tell him to make stress modification or control as he can, because it will helping him to control the disease, because the disease all the body is affecting his general life and affecting on him. So when he control all of this point with each other, he have a good effect inshallah, and he will improve it. We cover all the topic now. We could discuss about the shoulder, we discuss about the osteoarthritis. More or less we cover all the many point sharing between the rheumatology and orthopedic and almost all the joint. Thank you for this nice informative session, Dr. Ahmed. Hope our viewer also understand all of this information. Stay tuned for more healthy conversation, talking sets. See you inshallah. Bye.
Thank you, Dr.